وقتك وحضورك ان انت تديلنا المحاضره دي. ثانيا انا حابب اعمل زي انترودكشن للدكتور عمرو للجميع. الدكتور عمرو هو خريج جامعه عين شمس، مظبوط يا دكتور عمرو؟
القاهرة.
من القاهره، جامعه القاهره، دفعه 2007، واشتغل كنائب انترنال ميديسن في مصر فتره، وبعد كده جه هنا اشتغل، عمل النيابه بتاعته في جامعه مور هاوس في جورجيا في اتلانتا، وبعد كده عمل الهيماتولوجي او الانكولوجي تريننج بتاعه في كارمانوس اللي هو وين ستيت كانسر سنتر. وان شاء الله يعني هو بعد كده بيشتغل حاليا كاسيستنت بروفيسور اند دايركتور اوف نيوروإندوكرين تومرز بروجرام في كيس ويسترن ريزيرف اللي هي اليونيفرسيتي هوسبيتال في كليفلاند اوهايو. شكرا جزيلا دكتور عمرو، والوقت بقى ايه براحتك، ويعني شوف انت يعني السيت اب whatever way you want the interactions to be، عايزها بعد المحاضره خلال الكلام زي ما انت عايز.
شكرا يا دكتور حجازي. طبعا ممكن نخلي الانتراكشن في خلال وانا ان شاء الله بريزنت ماي سلايدز. لو اي حد عنده اي سؤال ان شاء الله ممكن يوقفني ويسال، وبرضه ان شاء الله بعد ما نخلص المحاضره لو اي حد عنده اي اسئله ان شاء الله ممكن نجاوب عليها. فليت مي جاست شير ماي سكرين. في الاول الصوت كده واضح؟ كلكم سامعيني كويس؟
واضح يا دكتور عمرو.
تمام. Can you see my screen؟
ايوه
تمام.
واضح يا دكتور عمرو، لو حضرتك تعمل لها F5 بحيث ان ايوه كده.
تمام. النهارده ان شاء الله هنتكلم على النيرو اندوكرين تيومرز، والمين سبجكت هيبقى الجاسترو انتيرو بانكرياتيك نيرو اندوكرين تيومرز، الاورام اللي بنسميها اورام الغدد العصبيه اللي موجوده في منطقه الجاسترو انتستينال تراكت. اول حاجه عشان نفهم، اما بيجي لي عيان العياده، اي عيان بتقول له you have been diagnosed with cancer, it's definitely stressful and scary for the patient, للفاميلي بتاعه، للcaregivers, everyone. But if you tell someone you have neuroendocrine tumors, I think it's even more scary لأن it's unknown. العيان ما يعرفش يعني إيه neuroendocrine tumors. وأكيد نفس الكلام العيانين في مصر مش متعودين على يعني إيه أورام الغدد العصبية. فأول حاجة بعملها إن أنا ببدأ مع العيان بفهمه يعني إيه neuroendocrine cells. It's a very, very small cells which can be found anywhere in the body, not only in the endocrine system. مش لازم انها تكون موجودة بس في الثايرويد جلاند، لا هي موجودة في أماكن تانية زي البانكرياس، زي السمول انتستين، موجودة في اللنج، في الجينيتال يورينري تراكت. والسمول سيلز دي لو قسمنا الكلمة جزئين نيرو اندوكرين، they need nerve stimulation so they can produce hormone or help the organ to produce hormone. بيعتمدوا في كل شغلهم على ريسبتورز، بعض المستقبلات اللي موجوده على سطح الخليه اسمها سوماتوستاتين ريسبتورز. فلو فكرنا فيها ده الاسم جاي من كده، نيرو اندوكرين، من نيرولوجي والاندوكرين سيستم، انتجريشن بين these two systems هي اللي وضحت لنا يعني ايه نيرو اندوكرين سيلز. فلو كلامنا بنقول ان هو موجوده في كل حته في الجسم، ف what is the most common size of neuroendocrine? It can be anywhere. So it can be in the lung, في الثايرويد gland we call it the medullary thyroid carcinoma. It can be في pancreas, small intestine, even sometimes large intestine. The most common site is the small intestine. So about 50 to 55% in the small intestine, about 20% في pancreas. فالgastroenteropancreatic neuroendocrine tumors almost 75%. عشان كده معظم اللي بيعالجوا نوع الاورام دي يعني هم الجي اي ميديكال اونكولوجيست اللي متخصصين في اورام الجهاز الهضمي. The second question I always get from my patients, I have been told they are very, very rare tumors. والكونسبت ده كان عندنا حتى واحنا في الميديكال سكول، يعني مش كناش بنشوف حالات كتير neuroendocrine tumors. فبفهم العيان ان yeah it has been that, shown at one time that they are very rare cancers, but that's not the case anymore. In the last like 25 years, there are more than 7 to 8 folds increase for neuroendocrine tumors. Not all of them incidents, some of them are prevalence. Neuroendocrine tumors بنعالجها زي chronic disease، فالعيانين بيعيشوا فترة طويلة مقارنة بأنواع الكانسر التانية. دلوقتي عندنا much better imaging modality. عندنا specific PET scans اسمها البيت نت neuroendocrine tumors أو الجاليوم 68, and very recently we have the PET copper 64. So you can even, get this diagnosis of these tumors even when they are very, very small, less than 2 centimeters. So you can definitely get them earlier. So you have better imaging modality, you have better pathological diagnosis for these tumors. So you can pick these tumors definitely at much earlier stage, but also there is some increase in the incidence. So both these 8 folds are not exclusively incidence, but definitely incidence is one of them. There's also a lot of environmental factors. We are not aware of all of them. So are they rare tumors anymore? Definitely the answer are not. When you compare it with other GI cancers, this is the second most common GI cancer after colorectal. For neuroendocrine tumors by itself, it's more than HCC, liver cancer, it's more than the anal cancer, and it's almost in the same level or maybe higher than pancreatic cancer by itself. And you can see here in the graph in the left side, neuroendocrine tumors, still, it is less than someone have colorectal cancer or breast cancer, like a definitely significant increase in the last 25 years. And the significant increase was in the most of neuroendocrine tumor, best special gastroenteropancreatic, for lung, bronchial, genitourinary neuroendocrine tumors, all of them are increasing with relative differences, but all of the neuroendocrine tumors are definitely increased in the last 25 years. الحاجة الثانية المهمة قوي الترمينولوجي. Neuroendocrine tumors واخدة أسماء كتير قوي. You can sometimes hear carcinoids, neuroendocrine neoplasms, neuroendocrine tumors, neuroendocrine carcinoma. Every one of them actually is different disease. Starting with carcinoids, that's a very old name. In about 1907, this pathologist, a German pathologist, he's a guy who really coined all the field of neuroendocrine tumors. اكتشف very, very small abnormal cells, and they call them carcinoid. It's not even an English word, which means cancer-like cells. He didn't think that that's cancer. He thinks it's abnormal cells. It still have some manifestations of the normal cells where they are coming from, but they look different. But he did not categorize them as cancers. He says just a cancer-like cells. And we still use this name until now, unfortunately. And it took the WHO almost 100 years until they redefined the carcinoid again, that, you know what, they are cancers, but they are slow-growing cancers. And there are 2 types. Slow-growing, what we call well-differentiated neuroendocrine tumors, or NETs, or it can be poorly differentiated aggressive cancers. We call it NEC, neuroendocrine carcinoma. So why are we still using carcinoid? Because the neuroendocrine tumors in the small bowel and in the lung, they can produce serotonin, one of the hormones which causing a lot of carcinoid features, diarrhea, flushing, wheezes. So we associate them with the terminology carcinoid. So when someone says this patient has carcinoid, most probably that's small bowel or lung. But if someone has neuroendocrine tumor in the pancreas, we don't say carcinoid, we say PNETs, or pancreatic neuroendocrine tumors. And this is different terminology. Every one of them definitely represent a separate identity of disease other than the other tumors. So the classifications is very important. Neuroendocrine tumors are not one disease. They are very, very heterogeneous. They depend where they're coming from, and this is the embryological classification, the foregut, midgut, and hindgut, and the pancreas, which mainly the midgut, we mean the small bowel neuroendocrine tumors. This is the most common one. And then according to pathological classification, differentiation, and grade, and I'm going to discuss that in a minute, what does that mean exactly? Are they really functional tumors or not? Are they producing hormone causing symptoms, or they are very silent tumors? What is the extent of disease? And this is can go with any other cancers. Are they localized or are they metastatic disease? And if they are representing or expressing the somatostatin receptors or not. So you can have 2 neuroendocrine tumors in the pancreas, and they are completely different. Completely different in the extent of disease, in the tumor burden, in the hormonal status, either functional or not. Are they really expressing somatostatin or not? And the treatment will be completely different. So 2 metastatic or 2 stage 4 pancreatic neuroendocrine tumor, the treatment of both of them can be completely different. And this is give you an idea how heterogeneous are these cancers. And this is an example of tumor burden. So this is a couple of scans from 2 metastatic pancreatic neuroendocrine tumor. You can see on the left side, the patient only have 1 mets in the liver. On the right side, definitely it's high tumor burden. How we approach that, both of them are stage 4. The treatment and approach are very different, as we are going to discuss in a minute. So the first thing that I look at when I have any new patients in my clinic is the pathological report. Neuroendocrine tumor need to have a comprehensive program. You need to have a pathologist with very expertise in neuroendocrine tumors, so he can or she can give you a comprehensive pathological report. And this is very, very important and critical. Starting with the stains. Who says that that's neuroendocrine, not a pancreatic adenocarcinoma? So specific stains like somatostatin, chromogranin, and the INMS1 now, it's one of the new stains coming, will be coming very soon at the end of this year as a specific markers for neuroendocrine tumors. دي أول حاجة بيعملوها عشان يقولوا yes, the lesion in the pancreas or the small bowel, that's neuroendocrine, that's not an adenocarcinoma. The second step will be differentiation and grade. Differentiation is how these cells looking like under the microscope comparing to the normal cells. It's just very simple. If they are very well organized as the one on the left side with maybe some differences from where they're coming from, we call it well differentiated. The nasty aggressive looking cells, that's what we call poorly differentiated. Why it's important to know what type of neuroendocrine tumor is that? Because the biology is different, treatment is different, and prognosis is significantly different. Well differentiated, most of them, we do not need chemotherapy. We have more like targeted and somatostatin receptor targets treatments. We don't use a lot of chemotherapy in them, except in very specific situation that I'm going to let you know about. Poorly differentiated are very aggressive neuroendocrine tumors. Unfortunately, the prognosis in most of them is less than a year. This is the most aggressive type of cancer, even more than small cell lung cancer. We only having the first line therapy from small cell lung cancer by using platinum etoposide chemotherapy. When it comes to second line, we don't have a very good data about it. Sometimes we're using immunotherapy, but the treatments are very, very limited. After we know what differentiation, we need to know which grade. Grade is how fast are these cells multiplying. And we use a specific protein called the Ki67, which is indicative of the cell proliferation, basically. And if any number below 3, we call it grade 1, 3 to 20, that's a grade 2. Anything more than 20, that's grade 3. So if someone have well-differentiated grade 1 and 2, the treatment most probably be completely different from someone have well-differentiated grade 3. So if you don't have these 3 important information in the pathological report and they are not very accurate, definitely will affect the type of image that you are going to get, but also going to affect your treatment. So this is the first most important step to treat any patient with neuroendocrine tumor, is to have a good pathological report. So in 2010, the classification was mainly well-differentiated, which is mainly grade 1 and grade 2, and then poorly differentiated. We consider any grade 3, in the early time that they are poorly differentiated. But that's not the case anymore. In 2019, you can see that there are grade 3 well-differentiated, but there are also grade 3 poorly differentiated. So the patient can have very fast proliferative cells, but they look well-differentiated under the microscope. These are completely different from someone having grade 3, but they are poorly differentiated. The imaging are different, treatment are different, and definitely prognosis are significantly different. So it's very important now that we go with the 2019 WHO classification, and we know that well-differentiated can be 3 grades, and poorly differentiated is almost grade 3. So what is the initial workup we need for these patients? Blood work, anatomical imaging, and functional imaging. When we talk about the blood work after we have the pathological classification, we always order tumor markers for most of our cancers. In neuroendocrine tumors, we have a tumor marker called chromogranin. Recently in North American Neuroendocrine Tumor Society, during our last meeting, we're removing that from the guidelines because it's not very specific for neuroendocrine tumor. There are a lot of types of foods and medications can affect that, and you should not depend on the level of chromogranin A to order specific imaging for restaging or to change your treatment. For example, we have a patient came to us, chromogranin A was maybe 200. Then we did the surgery. It was localized tumor in the pancreas. We removed it. After surgery, someone ordered chromogranin A. It came back 2,000. And then the patient, you can feel now that the patient is very anxious that my cancer is coming back. It's actually the surgery makes it worse. And I have to sit down with the patient and let him know that's not correlated with your neuroendocrine tumor. There's a lot of food and medications like banana, kiwi, avocado, stuff which have tryptophan that we're eating every day. They are very common. They can increase serotonin and they can affect the chromogranin A levels. So usually I don't get chromogranin A for follow-up for neuroendocrine tumors anymore. So do we really have any other tumor marker for neuroendocrine tumor? Unfortunately, we do not have. So we don't have any good specific marker. We're using some other pancreatic polypeptide and stuff like that, which is slightly correlated with neuroendocrine tumors, but the data are all over the place. So it's not really a strong data as well. When it comes to the imaging, CT scan or MRI is the primary imaging that you get once the patient has been diagnosed with neuroendocrine tumor. Is there any difference between CT or MRI? If the patient have liver mets, if you have any disease in the liver, I usually tell the patient to get MRI. They are much more specific than CT scan. You don't want to have a CT scan showing 1 or 2 liver lesions. Then you start your treatment. About 3-6 months, you do another MRI, you found 10 lesions. And then you ask yourself, now is my patient progressing? Should I change the treatment? I don't think he was progressing. I think you did not get the right imaging from the beginning. You need to have the MRI if the patient have liver lesions. لو عندهم lesions في منطقة small bowel والpelvis والmesenteric and peritoneal, we usually get a specific CT with angiography, which will have more specific visualization of all the lymph nodes. بس ما فيش اختلاف بينهم غير بس في الأماكن الأورام لو موجودة في الليفر أو لو موجودة في الليمف نود. لكن other than that, they're almost the same. When it comes to functional imaging, which is octreotide scan that we use it like maybe 3-4 years ago, and then I don't think anyone is using that anymore. We have a PET gallium-68 and PET copper-64. الانواع الايمجنج دي بنسميها functional لانك تقدر تشوف السوماتوستاتين receptors, and this is one of them here. You can see it on the right side. So this is image of someone had metastatic pancreatic neuroendocrine tumor with liver mets, and you can see that all the liver mets having somatostatin expression or uptake. This is a gallium-68. The octreotide scan with an old one and gallium-68 and copper-64 are much more specific and sensitive comparing to octreotide scan. So no one really using octreotide scan anymore. You can see much more lesions in gallium-68 and copper-64. Why it's important to get this baseline? Because this somatostatin expression really will affect your treatment choice. So there's a lot of treatment that we are going to mention in the next slides, depend if the patient has these somatostatin receptors or not. If they don't have it, they will not be qualified for this type of therapies, and you need to go to something different. So it's very important to have a baseline gallium-68 as well, or copper-64. What type of
سؤال؟
Yeah.
ده بصراحة سؤال للماركت في مصر. هل الجاليوم 68 او الCU 64 is available in Egypt ولا التيستس دي مش موجودة؟
لا، gallium 68 موجود. Copper 64 is still not yet, but there's no big difference between الجاليوم 68 والcopper 64. but gallium 68 موجود في مصر، يعني بيجي لي عيانين كتير من مصر اوريدي عاملين gallium 68. فهو متاح طبعا يعني. الحاجة الوحيدة اللي ممكن مهم نركز عليها هو الفرق بين السي تي والام ار اي، لان بيجي عيانين كتير عاملين سي تي سكان وبعدين في النص اتعمل لهم ام ار اي، وواضح ان في اختلاف جامد في اعداد الليجنز في الليفر، مثلا من 2 lesions ل 10 lesions. And then the patient wanna come and just change the treatment. But then you look at everything else في الايمجنج كلها stable. Everything outside the liver is stable. فتبدا تشك هل هو اصلا عنده بيس لاين من الاول 10 lesions بس ما تعملوش الام ار اي. فدي مهم قوي ان احنا ننبه عليها. لو اي عيان جالك عنده pancreatic or small bowel neuroendocrine tumor with mets to the liver, do the MRI from the beginning so you can have a good baseline. So how we treat this patient after we have the pathological report, after we have the good blood work, after we have the imaging. Before I say how we treat them, the blood work is driven by the symptoms. يعني لو عيان جالك عنده small bowel neuroendocrine tumor أو lung neuroendocrine tumors, and they having the features, carcinoid features, they having diarrhea, flushing, and diarrhea. most الدايريا بتاعت النيوروendocrine tumor واحد بيجي 7-8 مرات دايريا في اليوم كل يوم. عنده flushing، بتيجي زي episodes of flushing كل 10 دقائق وتروح. عنده wheezes. طبعا ممكن تختلف السيفيريتي بتاعت البرزنتيشن بس معظمهم بيجوا بالشكل ده. لو هو عنده الكلام ده you can order the serotonin. The serotonin you can order like a blood serotonin and that's not really specific. ليه؟ لأن السيروتونين الجسم بيفرزه في موجات، فممكن أقيس السيروتونين الصبح العيان وبالليل يديني 2 significant different numbers. فالأفضل حاجة اسمها urine 5-HIAA which is one of the metabolites of serotonin. And recently آخر 2-3 عندنا دلوقتي البلازما 5-HIAA. if you have either urine 5-HIAA موجود في مصر، صراحة مش عارف البلازما لو كان موجود في مصر ولا لا، بس هي دي التست اللي انت you should order it في عيان عنده small bowel أو lung neuroendocrine tumor. عيانين البانكرياس they don't secrete serotonin، بيفرزوا حاجات تانية whether insulin، الجاسترين ساعات بيفرزوا عيانين البانكرياتيك neuroendocrine tumor أو الديودينم neuroendocrine tumor، VIP somatostatin، كل الكلام ده. فهل لو أي عيان جالي pancreatic neuroendocrine tumor should I send all these hormones? Should I send the insulin, glucagon, gastrin, VIP? No, you shouldn't. It's only driven by symptoms. يعني لو عيان جاله عنده pancreatic neuroendocrine tumor, the first thing in your mind, 60% of the pancreatic neuroendocrine tumors are non-functional. They are not producing any hormones. The other 40% or maybe less, they're producing some hormones. فبقعد مع العيان ساعتها تبتدي تساله على الاعراض واحده واحده. بالنسبه للانسولين دي have any hypoglycemia episodes، وتساله على كل الفيتشرز بتاعت الهايبوغلايسيميا. هل انت السكر مؤخرا عندك بيعلى جامد قوي، you have an hyperglycemia and you think about the glucagon. Do you have any rash and extensive diarrhea, hypokalemia? So you have the VIP. So it's only driven by the symptoms. لو ما فيش اي من السيمبتومز دول you don't need to get any of the hormonal levels. لو أي من الهرمونات دي عالية سواء في البنكرياس أو السيروتونين for the small bowel and the lung, this is the tumor marker you need to follow up with. لأن الفكرة أما بيزيد أعداد الكانسر والتيومر بيردن الهرمون سكريشن هيزيد. فهو ده الرايت tumor marker clinically that really you should follow up with لو العيان من الأول عنده functional tumor. ليه محتاجه فعلا significant multidisciplinary management؟ لان زي ما قلت لك من البدايه الباثولوجيست مهم جدا ان هو يديك comprehensive pathological report. لو ما ادكش الرايت KI 67 you don't know the grade, you don't know really how the patient will behave. لو ما وضحش well differentiated from poorly differentiated مشكله كبيره، مش هتعرف تعالج العيان ازاي. لو ما وضحش الستيننج المعين السبيسيفيك، ساعات بيعملوا ستيننج للهرمونال سكريشن. يعني ساعات يقول لك small bowel neuroendocrine tumor والستين was positive for serotonin والعيان اوريدي عنده فيتشرز للسيروتونين، ساعتها هتعرف ان غالبا هو دون الهرمون سكريشن that you should follow up with. فكل الحاجات دي مهمه جدا انها تبقى موجوده في الباثولوجي ريبورت. الميديكال انكولوجي most probably he will be the director of the program لان هو putting everything together. Nuclear medicine is very important لأن لما تعمل الجاليوم 68 أو الكبر 64 لازم يبقى كل الليجنز expressing somatostatin receptor with a good intensity. لو مثلا واحد ليجن express somatostatin receptors والباقي لأ، العلاج هيبقى ineffective. فالنيوكلير ميديسين physician always opens the gallium 68 or the cover 64 with us in the tumor board and he's showing us all the lesions, how they express the somatostatin receptors. السيرجري is very important في المالتيديسبلينري مانجمنت، لأن حتى في الستيج 4 we can still go ahead and remove a lot of tumors, even from the primary tumor and the metastatic in the liver. What we call it cytoreduction. طب احنا ليه بنعمل كده في البانكرياتيك نيوروendocrine tumor او السمول باول، اختلافا مثلا عن الكولون كانسر؟ لو واحد عنده stage 4 metastatic disease most probably he will need systemic therapy. لأن النيوروendocrine tumors زي ما قلنا they are very very slow growing tumors. So basically you're resetting the clock from the beginning. You're trying to remove everything as much as you can. وفي نفس الوقت you keep a good quality of life for the patient. العين هياخد فترة طويلة عشان يحصل بروجريشن للكانسر تاني. فطبعا السيرجري دوره مهم قوي في الكلام ده. لو العيان عنده انسولينوما، جاسترينوما, any of that, we need a good endocrinologist. We need to follow up with the patient, doing the blood work for these hormones and follow up with that. The same for the cardiology. About 19% للعيانين small bowel neuroendocrine tumors والbronchial neuroendocrine tumors, they secrete serotonin and it cause carcinoid heart disease. لما بيبقى السيروتونين عالي في الدم والعيان عنده liver mets, the liver cannot metabolize the serotonin and it will go to the right side of circulation and it can go to the right side of the heart valves, mainly the pulmonary and tricuspid valves. And the patient will have tricuspid regurg, pulmonary regurg. This really will affect the survival of the patient. فلازم يبقى عندك كارديولوجي يتابع بالايكو كل فتره على حسب تغير حاله العيان لو هو عنده carcinoid heart disease. And he should know when to treat medically and when to refer the patient for valve replacement. So in multidisciplinary, it's not just a show of a comprehensive program. I think it's very critical for the patient's treatment. So the main treatment option for the gastroenteropancreatic neuroendocrine tumors, again, surgical debulking, what we call cytoreduction. That's still very important. Or we can sometimes, in a very limited situation like pancreatic neuroendocrine tumor, we give a chemotherapy as a conversion chemotherapy, something called CAP10, we are going to show in a minute. Liver impulization with a Y90 planned impulization. No one really doing chemo impulization anymore because it's very toxic with similar efficacy comparing to planned and radio impulization. بس ده لو العيان عنده exclusively liver mets and there is no any mets outside the liver. Or systemic therapy, and this is what we are going to discuss in details, what we call somatostatin analog, anti-angiogenesis, Sutent, Everolimus, Lutetium 177, واخر حاجه الكيموثيرابي الكابتن. So somatostatin analog, think about it like that. احنا عشان نعالج اي كانسر في معظم انواع الكانسرز بيبقى عندنا حاجه من حاجتين مهمين قوي. لا اما systemic chemotherapy, cytotoxic chemotherapy, you basically kill the cancer cells but also you kill some of the normal cells. او انك انت target your therapy to specific mutation that this cancer has. او specific receptors الكانسر لو عنده مستقبلات معينه زي السوماتوستاتين receptors. فالسوماتوستاتين that's a hormone that your body is secreting normally and it decreases any other hormones. So it decreases the insulin, glucagon, serotonin. So basically هرمون بيقلل كل حاجه ثانيه موجوده في الجسم. بس مشكلته ان الهاف لايف بتاعته اقل من 2 minutes. So if you think about it logically, you cannot treat your patient every 2 minutes. You need something long acting. And this is where is the name coming, somatostatin analogs. And there are 2 somatostatin analogs in the market. والاثنين دول موجودين في مصر. Octreotide with something called somatulin or linarotide. Is there any difference between both of them? Octreotide, we give it intramuscular. It's deep intramuscular. And you can start usually with 30 milligram, and you can go up to 40, 50, and 60. Somatulin or linarotide is 120 milligram, and it's subcutaneous. So technically, there is no any difference. They are both the same efficacy. They are both somatostatin analogs. They are used to decrease the hormonal secretion, but they also have another benefit as well. These were 2 phase 3 clinical trials, the PROMET trial and ClearNet trial. PROMET trial استخدموا الأوكتريوتايد في ناس عندها metastatic, mainly mid-gut. When I say mid-gut, I mean small bowel neuroendocrine tumors. وواضح ان هو بيقلل السيروتونين الهرمون secretion, فاليورين 5-HIAA was significantly decreased with octreotide. But also when you look at the graph here, it's also delay the progression of the cancer. So definitely it is improving progression-free survival. This was a phase 3 study. There are a lot of phase 2 and phase 1 study was done before that. The CLARINET trial, they're using lenalidomide in more variety of neuroendocrine tumors, pancreatic, small bowel, bronchial, and other unknown. And also it shows that definitely it decreases the hormonal secretion, but it also improves the survival, improves the progression. So it improves the progression-free survival. فلو بصيت على فرق الاثنين استادي هتلاقي في فرق، واحد استخدم في السمول باول بس، الثاني كان في السمول باول pancreatic, unknown, bronchial. Does that mean if someone comes with pancreatic, should I only use lenalidomide? I shouldn't use octreotide? No, that's not the case. They are all the same mechanism. بس الاستادي اتعملت بالطريقه دي، لكن احنا بنستخدم الاثنين between each other. There is no any differences. The only big difference لو عندك someone slightly more obese, deep intramuscular can be more complicated with abscess, more painful, and I'm not sure about the bioavailability of the drug لأنك مش هتقدر تدخل deep intramuscular لحد المصل ويحصل absorption كامل للدواء. فساعتها في الأوقات دي بستخدم حاجة subcutaneous تبقى أسهل زي lenalidomide. Maybe this is the only difference. So when we are using somatostatin analog, initially or just overall, they are very well tolerated medications. They don't have a lot of side effects. The most common side effects, some abdominal bloating, gas. If the patient will be in somatostatin analogs for a long time, they can have decrease in the gallbladder contractility, so they can get gallbladder stones. But overall, it's a very well tolerable medications. We have a very high level of evidence that they are both decreasing hormone secretion, but they also decrease the progression of the cancer. They improve the progression-free survival. We use it for the patients who have low tumor burden, metastatic gastroenteropancreatic and bronchial neuroendocrine tumors. Why we use them in the low burden? Why we don't use them in someone have a lot of disease? Because the response is not that impressive. It is something less than 3%. فلما ابدا العيان على الدواء ده لازم اقول له ان انا اول ما هبدا الانجكشن مره كل شهر هنعمل ايمجنج كمان 3 ل 4 شهور. Don't expect that you will find everything smaller. If I found everything stable, that's what I'm looking for. So لازم توضح له النقطه دي مهمه قوي، لانك لو بدات على العيان وبياخد انجكشن وابتدى يجي له شويه سايد افكتس بسيطه، بلوتنج، جاز، ستاف لايك ذات، وبعدين جه بعد 3 شهور عملت الايمجنج لقيت كل حاجه ثابته، هيقول لك الدواء ما بيشتغلش. فلازم تفهمه ان الميكانيزم بتاع الدواء hopefully it will keep the lesions stable for a long time. And definitely we have a very good evidence about that. How about if the patient, you start the medications on them and then they start having more symptoms, they're having more diarrhea, more flushing, or you know what, it's controlled only for 2-3 weeks, and then by the 3rd week, everything coming back again. You can do it every 3 weeks instead of every 4 weeks. Or now we have a trial called Forte trial, that you can give lenalidomide every 2 weeks instead of every 4 weeks. So definitely you can increase the dose. It's mainly for octreotide, or you can increase the frequency for both of them to control symptoms. Once they progress on them, you should not increase the dose to stabilize the cancer anymore. So you can increase the dose for hormonal secretion. Like to stabilize the cancer, that it shouldn't be the way. You should go to another treatment after that. The second treatment, which has been approved very recently in 2018, something called Lutethera or PRRT, which is peptide receptor radiotherapy. والفكرة معتمدة على نفس السوماتوستاتين انالوج بنستخدمه، بس attach with it بتحط radionuclide material, something called lutetium-177. فبالتالي بيدخل على أي neuroendocrine tumor which have the somatostatin receptors attached to the receptors and give a very concentrated radiation. And this is coming back to the first point. If you don't have a good imaging, the PET gallium-68 or copper-64, you will never know if all the lesions having the receptors or not. So the somatostatin analog as a first line, or even PRRT as a second line, can be useless because you don't know what is the status of the receptors. So the most important predictive biomarker for response for either somatostatin analog or PRRT are the expression of the somatostatin receptors in all the tumors. And it should be a good intensity of expression. So how we give this treatment? It's an IV treatment. It's not an external radiation like what we do with other radiotherapy. It's an IV treatment that we give it once every 2 months. And you can give it for only up to 4 treatments. فالschedule بتاع التريتمنت كله is only 8 months. Every 2 months you only give 1 treatment. And this was done actually in Europe for more than 15 years, but there is no any randomized phase 3 trial until recently in 2018. We have the NETTER-1 trial with Dr. Strasberg at Moffitt that basically he start giving patients who are progressing on somatostatin analog. We have metastatic gastroenteropancreatic neuroendocrine tumor. They give them, this is PRRT or Lutethera in addition to the somatostatin analog versus only somatostatin analog. And you can see that's one of the very impressive graphs that we really don't see it, like every day in the solid tumors. Definitely Hijazi is much more lucky in hematological malignancy, but we don't see that in solid tumors. So you can see here that the progression-free survival is significantly different. How long it will take until the patient will start progressing again? It's almost about 24 months. So the patient most probably will be stable for about 24 months. Usually after that, we start seeing some progression. Some patients less than that, some patients more than that. And it has like more than 80% reduction in risk of disease progression or death. The trial was mainly in the mid-gut. When they did some retrospective for pancreatic neuroendocrine tumors, it's almost the same numbers, but even slightly can be more. It can reach up to like 40 months. بس دايما بشرح للعيانه لما بيحصل progression على السوماتوستاتين analog, we are going to start the PRRT to stabilize your cancer for hopefully a couple of years. And then after that, if it starts progressing again, the question with, should I take it again? The data are very, very limited. There is no any prospective data about that. But there's some retrospective in Europe and Germany showing that you can give another 2 treatments and maybe another 2 treatments. So the total of all the PRRTs the patient can receive, it is only 8 treatments, 4 in the beginning, and then maybe 6 months or 1 year or 2 years after they progress, you can do another 2 treatments. If they progress again, you can do another 2 treatments. Why is that? Because I want to show you first the response before we talk about the side effects. The response, as you can see, objective response rate was only 18%. So yes, we see some lesions are decreasing in size, much better than somatostatin analogs, which is only 3. But it's not also impressive. So most of your patients will have stable disease for a long time. When it comes to the response, it may be hopefully higher than somatostatin analog, but that's not my primary target as well. So my primary target is to have a stable disease for a long time. They're also showing in the trial, and we're having the new results coming for survival, that also it's improved overall survival comparing to the high dose somatostatin analogs. So when should we use the PRRT? Again, we have a very good evidence. It's a phase 3 trial. You can use it in any pancreatic or small bowel neuroendocrine tumor metastatic after they progress on somatostatin analog. This is now officially the 2nd line of treatment, but definitely the patient should have a good somatostatin expression. If they don't have it, they will not be qualified for the treatment. Again, we can do 4 treatments, and if the patient progresses, you can do another 2 and maybe another 2 in the future. So the total will be 8. You cannot exceed more than that. There is some side effects and some concerns. When we talk about concerns, if someone has small bowel neuroendocrine tumors with a lot of mesenteric lymph nodes, I'm not really favorable to give this treatment to these patients because this targeted radiation can cause what we call desmoplastic reaction, a lot of inflammation in the cancer cells before they start to decrease in size. And if that's happened, the patient can have bowel obstruction. So you either give them steroids before you start treatment. So hopefully you can decrease the level of inflammation, and hopefully you can decrease the chance of getting bowel obstruction, or you found another therapy for them. So this is coming where is the radiologist is the critical person in the multidisciplinary board, so they can showing you if the patient have a lot of mesenteric lesions or not. Also, if the patient have extensive peritoneal disease, would be the same. I usually starting steroids in these patients. So mesenteric and peritoneal, both of them can have a desmoplastic reaction and bowel obstruction. If the patient does not have a lot of somatostatin expression, maybe one of the lesions, as you can see here in this picture, lighting up, having the somatostatin expression, but then the other lesions does not have the somatostatin expression, very heterogeneous. This patient is not a good candidate for PRRT treatment, and you need to find another treatment. because the medication is not going to attach to the receptors. It's a very heterogeneous receptor expression. So they need to have expression in all the lesions, not only in one of the lesions. If the patient has a high-grade disease, if the patient has a grade 3, even well differentiated, most of them, they don't have a very intense somatostatin expression, because somatostatin expression mainly in grade 1 and grade 2, and some of the grade 3 well differentiated. Poorly differentiated, in 99% of the cases, they don't have somatostatin expression. So if the patient have a high grade, either well differentiated or poorly differentiated, and most probably they don't have the receptors, they are also not good candidate for the treatment as well. So when it comes to the side effects, before I go to the other targeted therapy, the most common side effect, think about it, it's a targeted radiation. It can affect the bone marrow, so the patient can have myelosuppression. In the study, only less than 2% have an MDS, myelodysplastic syndrome, and acute leukemia. We don't see it here as often, to be honest with you. That was more like an international study. We don't know what is the background of some of the patients, but it's very rare. If you have 100 patients, maybe 1 or 2 patients will get something like that. It also can have some renal toxicity, so it gives the patient a lot of fluids and amino acid. So the treatment is once every 2 months, but the patient, when they come this one time, they spend almost 8 hours. You put 2 PEC lines or med lines, you're starting fluids, you're starting nausea medications, you're starting amino acids, so hopefully you can increase the excretion of the medication and decrease the nephrotoxicity. So it takes a long time to prepare your patient, and then the treatment only takes about 45 minutes. But this is one of the most common side effects as well. Another treatment is Everolimus or Affinitor. About 20% of the patients with neuroendocrine tumors, maybe slightly higher in the pancreatic, they express the mTOR, one of the protein which helps the cell proliferation and metastasis. So basically, we have an mTOR inhibitor, which is called Everolimus, that we're using for patients who have metastatic pancreatic and small bowel neuroendocrine tumors. There have been 3 trials done for Everolimus in the metastatic gastroenteropancreatic. And then you think about it, why they did 3 trials? 1 trial is more than enough. Because every trial representing a specific part of the puzzle, like is it a small bowel, is it pancreatic, is it bronchial, is it functional, is it non-functional? It's showing you it's very heterogeneous disease. So the Radiant 2 was a trial in patients have a small bowel and bronchial carcinoid, so they are functional small bowel and lung neuroendocrine tumor. They use the Everolimus plus octreotide versus octreotide by itself. And you can see there was definitely some slight increase or improvement in progression-free survival. But when you look at the hazard ratio, is only 0.77. And the confidence interval, definitely you can see that this is almost a negative trial. When they did the same trial in the pancreatic neuroendocrine tumor, definitely it's different. They have a very good progression-free survival benefit, almost about a year, about 11 months. When they did the same in the non-functional small bowel and lung neuroendocrine tumor, is still having a very good evidence of benefit from progression-free survival. So if I have 3 patients, 1 of them was functional small bowel and lung, this is the least evidence to use Everolimus for them. But if you have pancreatic neuroendocrine tumor, whether functional or not, or you have the non-functional small bowel or lung neuroendocrine tumor, both of them, they benefit from Everolimus, and you can use it as one of the targeted therapies. The trials also showing that there's improvement in overall survival, but wasn't really impressive in all of them. It had a lot of adverse events. The most common, it can cause pneumonitis, it can cause mucositis, a lot of mouth sores, it can cause colitis. Usually we give it to the patients with marshmallow or like something they can put it on it. So basically it will not attach to your mucosa. And they did this trick in one of the breast cancer trials, and we use it definitely in our patients. And they at least having less mucositis to compare to other patients who can take it just by itself and it touches the mouth mucosa. It also can elevate the blood sugar, can cause hyperglycemia. So if you have a patient with insulinoma, like neuroendocrine tumor secreting insulin, maybe you can use Everolimus in them as a good option if they have metastatic disease. And pneumonitis is one of the most serious side effects, but it is rare. It's something less than 3%. When should I use the everolimus again? It's a strong evidence really in pancreatic and in the non-functional neuroendocrine tumor of the lung and the small intestine. The weakest evidence we're using for the functional or the mid-gut neuroendocrine tumors, the functional mid-gut. The safety profile can be challenging. Maybe someone has diabetes and have metastatic neuroendocrine tumor. That's not the best option for them. So you need really to talk about the comorbidity before you're starting this treatment. If the patient is old age, usually I go with 5 milligrams. The medication is about 10 milligrams. You give it once every day. But if the patient are older or have diabetes, I go with lower dose comparing to other patients. Sunitinib or Sutent, one of the other targeted therapy, but this time not for the mTOR, it's for the anti-angiogenesis. It's a VEGF multi-kinase targeted therapy. We use it again mainly in the pancreatic neuroendocrine tumor because the phase 3 trial was done exclusively in the pancreatic neuroendocrine tumors. So if you have someone with a small bowel, they are not qualified for Sutent because there is no really a good evidence that it's working in small bowel as well. And in the phase 3 trial for metastatic pancreatic neuroendocrine tumor, still showing definitely significant improvement in progression-free survival, about 11.4 months comparing to 5.5 months. It's about a year for both of them, either Sutent or Everolimus. The patient will be almost a year stable in the disease, and then they start progressing. And this is the median average time. It also has some side effects, including hypertension, cardiovascular problems, diarrhea, nausea, fatigue. So when it comes to using, for example, if you have pancreatic neuroendocrine tumor now, and the patient start progressing, either in somatostatin analog or PRRT, and now you want to think, should I give Sutent or should I give Everolimus? I go with the comorbidity. So if the patient having diabetes and underlying lung disease, definitely Everolimus will be not a good option because it causes hyperglycemia and pneumonitis. So I go with Sutent in these patients. If the patient have uncontrolled hypertension, cardiovascular disease, any other vascular problems, I will go ahead and choose Everolimus and not Sutent. So there's no any trial to compare both of them head to head. And it is not really excited to compare both of them because they're almost the same efficacy. The only thing is the comorbidity, which will really driven your decision at this point. The CAPTEM, as you can see, most of our treatment are not chemotherapy. We're using CAPTEM mainly in pancreatic neuroendocrine tumor. After a retrospective study has been done at Moffitt with Dr. Strasberg again, he using the capecitabine and temozolomide in patients having metastatic pancreatic neuroendocrine tumor with a very, very impressive response rate, about 70%. Again, that's retrospective, having some bias, so you cannot say that the response is 70%. Almost most of the cases between 30 and 50%. As the dose is very, very important because it's different than other doses of capecitabine. We're using the 750 milligram PID from day 1 to 14 and temozolomide 200 milligram from day 10 to 14 every 28. So 2 weeks on and 2 weeks off. Another study has been done very recently, which is prospective, comparing temozolomide with CAPTEM, and this is what was discussed in ASCO 2018, and also showing a very good response comparing to the temozolomide itself. It also showing definitely improved progression-free survival and overall survival. So the main reason why I use chemotherapy, or should I use chemotherapy, when the patient have a high disease burden of pancreatic neuroendocrine tumors. As you can see here, these are some patients having a lot of disease in the liver, and you can see very impressive response after they did the CAPTEM. We use it for about maximum maybe 8-9 months, not more than that, because alkylating agents after that can cause a lot of hematological malignancy, and we definitely don't need that for our patients. So when should I use the CAPTEM? It's a very high response rate, but also having a lot of side effects, cytopenia, like myelosuppressions, fatigue, nausea, vomiting. So I use it if the patient really having high burden disease from pancreatic neuroendocrine tumors mainly. The results are even more limited with suboptimal response in small bowel and bronchial neuroendocrine tumors. Do we use them sometimes? Sometimes, but it's not very impressive. And we use them mainly to decrease the cancer, so hopefully we can go for surgery or at least as a palliative for the symptoms that the patients have. And mainly, again, the very strongest with the pancreatic neuroendocrine tumor high burden disease. I'm talking about grade 1 and grade 2 well differentiated, but you can also sometimes use it for grade 3 well differentiated. If we talk about what is the difference between Everolimus, Sutent, and CAP10, the biggest difference, I think, is median progression-free survival was definitely significant than both of them, which means your patient can be stable after the treatment for about almost 2 years. And the response, again, 30 to 40% in most of the patients, so the response is much higher comparing to Everolimus and Sutent. To summarize everything, if you start your patient in Everolimus or Sutent, you expect disease stabilization for almost a year. You don't have a very good response. It's something less than 9%. If you are going to start the patient in CAP10 because they have a lot of disease, the response is about 30 to 40%, and they can be stable almost 2 years after they finish the treatment. But they pay the price of the side effects. Just one slide on the hepatic arterial impulization. This is if the patient only have liver lesions with pancreatic or small bowel. They don't have any other lesions outside the liver. Definitely referring them to the interventional radiology to go ahead and do the Y90 or planned impulization will be your next option. Which one is better? Is planned or Y90 or TACE? There's only one trial now at UPenn. It's a prospective trial at University of Pennsylvania is going, so we're waiting for the results. But that's mainly between planned impulization and TACE, the chemotherapy. There is no any study comparing planned impulization with Y90. So it usually depends on the side effects. One of them having more intrahepatic abscess, the other one is more painful. And the interventional radiology is definitely able to help your patient to choose the right procedure for them. If you are going to do Y90, keep in mind that these patients may be qualified for PRRT or Lutethera in the future if they have more systemic disease or if they are start progressing. There is no data showing that the Y90 will increase the liver toxicity after doing that before the PRRT. But it makes sense because this is radiation, targeted radiation, and the other one also is targeted radiation. So maybe if you did a couple of Y90, the patient may be at higher risk to develop liver toxicity if they are qualified for PRRT in the future. So that's something you should keep it in mind. Definitely discuss with your interventional radiologist and make sure you choose the appropriate procedures for your patients. So what are the future treatments that we are waiting for in the field of neuroendocrine tumors? Maybe 20 years ago, we only have the somatostatin analog, PRRT, Everolimus, Sutent, CAP10, all that coming in the last 15 years. So before like 20 years ago, we only have one treatment for this patient. You can see it's very exciting time for this field, a lot of advance in therapeutic options. There are three concepts how we treat this patient. The somatostatin receptors by using the somatostatin analogs and PRRT. So in this concept, there's some advances going on right now using somatostatin antagonists, not agonists, which have more affinity to attach to the receptors. So hopefully the response can be slightly better, and maybe the efficacy will be better. We're still waiting for that. The somatostatin analogs, we give it as injection, as we said, intramuscular or subcutaneous. Now we're having some companies are working to get us somatostatin analogs that you can give it at yourself at home. It's a very slight superficial subcutaneous, or some of them are oral medication that can be hopefully in the future. So we don't need to go for any injection. For the PRRT treatment, we're using the lutetium-177 or Lutethera, which type of beta radiation. We have the same concept, but we're using alpha targeted therapy. And definitely this is the future for neuroendocrine tumors because the phase 1 trial showing almost 100% response rate. A lot of them definitely partial response, but also significant amount was complete response. The alpha radiation compared to the beta radiation have more double strand DNA damage. So it have more efficacy for the response, but and have also more tissue penetration and slightly less side effects. So definitely this will be replacing hopefully the lutetium-177 once we go to a phase 3 trial. We're still in the phase 1, phase 2 trial time, so still needing some time for that. When we talk about the anti-angiogenesis, we have the Sutent, mainly for pancreatic neuroendocrine tumor. when you think about it, we don't have the same target for small bowel. So they did a phase 3 trial international with using sorafenib, which is anti-VEGF, but also anti-FGF, fibroblast growth factor receptors. And it's showing a very good response in progression-free survival in both of them, pancreatic and mid-gut neuroendocrine tumors. It's going to be FDA approved very soon as well. There's another medication called Capazontina, which is also multi-kinase inhibitor. And we're having that in the phase 3 trial now for both of them, pancreatic and mid-gut. So hopefully these two options in the next couple of years will be available for our patients. Immunotherapy, unfortunately, we don't have a lot of success with immunotherapy because most of them, especially the grade 1 and grade 2 well differentiated, are what we call, they are cold tumors. One of the markers helping to choose the immunotherapy is something called tumor mutational burden. Very simply, how much of your immune cells are around the cancer. And most of these cancer, for some reason, the cancers are outside and not really entering to the environment of the tumor. So we don't have a very good tumor mutational burden and MSI high percentage in these patients. So immunotherapy is very limited, but now we use it as a second line for poorly differentiated neuroendocrine tumor. We almost all the study in well differentiated was negative across the board. But we're having now some idea to add some of the anti-angiogenesis like bevacizumab, Avastin plus immunotherapy to hopefully enhance the tumor mutational burden and enhance the efficacy of immunotherapy. We have a phase 2 trial showing some promising effects, but we're waiting to go for a phase 3 trial. So summary, if you have a mid-gut neuroendocrine tumor, mainly the small bowel, you need to do the gallium-68 or copper-64. If you have somatostatin expression, you start with somatostatin analog. If they're progressing, you can do the PRRT. If they only have liver disease, hepatic arterial impulization will be your option. One of the targeted therapy will be Everolimus. Again, it's a very weak evidence if the patient have functional mid-gut neuroendocrine tumor and they're producing hormone. I use it more for the patient who have non-functional mid-gut neuroendocrine tumor. Pancreatic neuroendocrine tumor, again, you do the gallium-68, you have the receptors, start with somatostatin analog, especially if the patient does not have a lot of disease. If they have a lot of disease and you need to go ahead and decrease that, you go with the chemotherapy. Otherwise, again, you go with PRRT if they have the somatostatin analog. You can choose between Everolimus and Sutent according to the comorbidity of your patient. And only if having liver disease, hepatic, again, directed therapy will be the option to go. So I'm just finishing here. Definitely, if anyone have any questions, this is my email, guys. You can email me at any time. And thank you for listening. This is the neuroendocrine tumor, basically signs that we use, which is the zebra. You use it because neuroendocrine tumor has been shown or has been known for a long time as the unknown cancer, not the rare cancer specifically, but the unknown. So thank you so much for listening to me.
Thank you, Dr.
Any questions? I'm ready for you.
Thank you, Dr. Amr. Hey guys, if there is anyone who has any question for Dr. Amr, we are more welcome than to hear that. So
السلام عليكم. عارف شكرا جزيلا دكتور عمرو. والله انت عارف انا كان نفسي وانا في سنه اولى في الهيمونج فيلوشيب ان انا احضر محاضره زي دي علشان افهم النيورو اندوكرين تيومرز بالشكل اللي انت شرحته ده بصراحه.
I was in the fellowship with you, so I didn't have any experience with that time.
يعني هي فرصه عظيمه جدا بصراحه للي في اول التريننج بتاعه ان هو يشوف الديتيلز ديت بالاب تو ديت انفورميشن بتاعتها دلوقتي، لان هو فعلا الراريتي بتاعته في الدايجنوستس في مصر despite انه it's not that rare بيخلي ايه ان هو طبعا التريننج والاديوكيشن والفوكس ليكتشرز عليه مش كتير. بس ان شاء الله يعني الموضوع دوت هنكمل فيه يعني with the whole GI tumor board ومعاه النيورو اندوكرينز ان شاء الله يعني مع حضرتك لما نبتدي الجي اي تيومر بوردز بعد رمضان بعون الله
باذن الله ان شاء الله.
وكان في حد عنده اي سؤال او حاجه؟
أنا أعتقد كانت المحاضرة واضحة و verified يعني.
طبعا لو حد عنده اي سؤال ان شاء الله انا حطيت الايميل بتاعي في السلايدز، وان شاء الله I will send it to دكتور حجازي also he can share it with you guys. لو اي حد عنده اي سؤال ان شاء الله feel free to contact me ان شاء الله.
والمحاضرة دي إن شاء الله تبقى متسجلة على اليوتيوب، لو حد يحب يرجع لها ويبص على الإيميل أو يبص على أي تفاصيل تانية تبقى موجودة على اليوتيوب إن شاء الله.
شكرا جزيلا، شكرا جزيلا، شكرا دكتور عمرو.
شكرا دكتور حجازي. السلام عليكم.
السلام عليكم.
عليكم السلام ورحمة الله.